and then iMac. Go live on TikTok. Live on TikTok.
You're live. Excellent. Hello, everybody. I am Dr. Rahi Victory. Welcome to Fertility Fact or Fiction, our show every week where we share the latest and greatest in all things infertility. And we do have a pretty exciting show for you tonight. I've got some interesting news and reviews from our recent Midwest Reproductive Symposium in Chicago. And there was some interesting information that was there, some that kind of verified what we already know, and some new stuff that I'll kind of touch on tonight. And then we have a great topic, which we were hoping to present recently, but didn't get a chance because we had some wonderful guests on the show. But we are going to present that to you tonight. And it's all about whether or not you should stick to the same cycle or you should change your cycle up in order to get better results in a second try. So I am here with my esteemed colleague and wonderful friend, quote unquote doctor, because he doesn't have a medical degree, Tarek Ibrahim from Ibrahim Strategies Group, who runs our life in all things social media. And we've got this great show for you tonight. So hang on to your questions, or you can pose them now and we'll get to them after we're done the initial part. But I definitely want to review with you some exciting things that came out of the Chicago conference. For those of you that aren't familiar with it, it's a relatively small conference, but it's extremely, extremely well done. It's run by the illustrious Angie Beltzos from Kindbody in the US, and she does a great job of organizing this. My dear friend Scott Nelson from the UK is the scientific organizer, and he pulls in all the data and the speakers and so on. So great conference, a lot of good talks. Interesting that they finally had someone talk about the importance of the microbiome. I've been talking about how important the microbiome is. Of course, we've been testing for it for years now and treating for it. And I do think it makes an absolutely massive impact on your success rates. So that's been a huge thing. And then it was great to see it come out in the conference. Very, very important. Additionally, there was a absolutely phenomenal talk given by one of the world experts in endo, Dr. Stephen Young, and he had a great chat, which essentially repeated everything we include in our endo protocol, but it actually didn't even go as far as we go with our endo protocol. So he talked about the importance of the immune system with endo, the fact that most people are not catching that, the fact that endo does matter, that yes, of course, there will be patients that get pregnant successfully with IVF if they're undergoing endo, if they have endo, but at the same time, there are many patients that will not. And whatever percentage that is, we are missing them by not treating them appropriately, or we're costing them a lot more by making them do multiple rounds of IVF. And interestingly, I went up to him and I asked him, what can we do to inspire other doctors or to convince other doctors to actually pay attention to endo? And he literally said, I don't know. There is no way to do that. So fascinating talk. It was great to see everything that we've presented actually on the show, presented at this conference, and kind of rehashed and rejigged a little to present what he was trying to get across. But it was fascinating information. And he actually talked a lot about how your diet, which is very unusual for a Western academic trained scientific individual, can impact your risk of developing endo. And he did talk about the fact that any kind of inflammation in the body can predispose to endometriosis. So eating a healthy diet might actually make a difference. And they think it's bad enough that people who have insulin resistance may actually be at a higher risk of endo. And so that also gives us an opportunity to look at places where we might be able to target treatment, like using metformin to reduce that component of the inflammation. So if you have endo and you're struggling with weight and you have insulin resistance, it might be better, in addition to all the other things we do for endo, to actually consider doing a metformin or insulin control medication or therapy in order to improve the inflammatory index that's there. The last thing that was really, really cool from this conference was a talk by a gentleman whose last name is Patrizio. And he talked about his success rates with women, and I hesitate to say this because it's going to make the internet go crazy, for women over the age of 45 trying to do IVF. Now, traditionally, when I'm speaking to those women, I basically tell them, look, I'm more than happy to help you. We can try. I had this discussion today with a patient, but the chances of success are extremely, extremely low because of complications with genetics. And the fact that even if we can get eggs, there are so many aneuploid embryos that it's probably not worth it. He actually went into a great deal of detail on the fact that it looks like eggs that are in the ovaries in women who are older actually start to get progressively more deprived of oxygen. So up until 40, you're okay. Between 40 to 45, it gets a lot worse. And then after 45, it's even worse. And so what he's actually proposing, and he's done it, and he's actually published on it, although the numbers were absolutely negligibly small, is getting eggs out when they are still immature, maturing them in the laboratory, and then using those matured eggs. And the idea behind it is if we get the eggs out of their kind of hypoxic, low oxygen environment and get them into an oxygen-rich environment as early in their development as possible, we may actually be able to get better eggs. Now, he claims it works. I did read his study, and my embryologist reviewed it today, and she's absolutely brilliant. So thank you so much, Dr. Khosravi, for your excellent review. I mean, the numbers are very small. And he did say something to me that actually wasn't what he did in the study regarding the type of media that he used. Nevertheless, it looks very, very promising that there may be an opportunity, at least for research. So please don't call scrambling to get into this. We don't have a protocol yet. But there may be an opportunity on a research basis to start treating women who are substantially older in their reproductive years, over 43, using their own eggs and trying to get follicles that are immature, mature them, and then use those follicles. Now, unfortunately, there's no live birth data, which is super frustrating. And he also didn't comment on the genetics, which is additionally very frustrating. But it does look very promising. And in combination with some other treatments, this may be a potential game changer. So we are going to look into a protocol. We're going to bundle a couple of cycles together. We're going to actually include the drugs in our program. We're going to do it for a kind of a rock bottom price to see if we can help those patients, because we know they are definitely struggling and taking a huge risk. But I think there might be something to this. I mean, the physiology, the biology of what he's proposing, he had good evidence for it, made a lot of sense. And I think there may be some hope in there somewhere for us to try and get a good result. My lab director, Dr. Khosravi, did mention that she had tried this years ago, and they ended up with a lot of what's called 3' eggs and embryos. And so that might be more of a problem. And so we don't want to end up with genetically abnormal embryos. However, it does make sense to at least give this a shot if the evidence supports doing it. So we will have a new protocol, hopefully relatively soon, to help those patients, who are struggling because their age has gone up, but they are desperate not to use donor eggs. This by no means that we shouldn't still promote donor eggs for that age group. It's far and away going to give you a better chance. But in combination with some other techniques that we are exploring, it may be useful. And I had the opportunity to sit next to the lovely Amy Evazada. She ran over and said hello because we know each other. And we were talking about what she does, and I talked about what we do. And we talked about maybe looking at how this could work for us in combination. So we're going to kind of borrow off of one another and see how that can work. So Amy, I'm not sure if you're watching or not, but if you are, thank you for your insights as well. And she gave a lovely talk at the conference about whether or not we should be doing various treatments with IVF. So it was a very, very interesting chat about what to do. And it was mainly on the use of ICSI versus non-ICSI and whether or not we should be doing it. So anyways, just thought I'd share what I learned at the conference. Overall, a good meeting. Fantastic city in Chicago. So if any of you are watching from Chicago, Beautiful, beautiful place. Have you been to Chicago?
I love Chicago.
I love Chicago. It's an awesome city. Although I will say, I ate at my favorite restaurant, the Fig and Olive.
Mhm.
Wasn't as good as I remember it.
Really?
It was very good, but it wasn't as good. I
No.
think it was so rushed and they're so busy that quality's kind of
Dropped.
fallen a notch. Yeah. But then I went to the 11th City Diner, which is my favorite
Oh, that's your go-to.
breakfast place in the world.
Yeah, yeah, yeah.
Unbelievable. It's so good. Yeah, so great breakfast, but the dinner, it was all right. Okay, and thank you, by the way, to our friends at Fairing, who have not paid for any of this whatsoever for the show, but they did sponsor me to attend the Midwest Reproductive Symposium. So thank you very much, guys. I greatly appreciate the opportunity to be at the meeting and to learn there. So thank you for all the sponsorship and for the help and so on. Okay, so we can share. You good with sharing?
Mhm.
So tonight's topic is from human reproduction. The authors are from a variety of different places, but mainly from the Albert Einstein College of Medicine and Mainline Fertility in Bryn Mawr, Pennsylvania. My sister actually lived in Bryn Mawr for some time. And then Columbia University. So kind of a bunch of different places. They had Coral Gables, they had White Plains, New York. So several different authors from several different places. So what they looked at was the SART database. So SART is the Society for Assisted Reproductive Technology in the US, and they force all the IVF centers to report to them. And they compile that data and then they issue reports every year. And it's a mandatory report. You get in all sorts of trouble if you don't do it properly. So they took their database and analyzed what happened to patients that had a previous IVF cycle that was canceled, and then they made a change. Okay, so if for whatever reason you're a poor responder, you're a good responder, whatever, but your cycle got canceled, what happened if you made a change? And they actually looked at the protocol and what changes were made, and then talked about what the outcomes were. And they were mainly looking at live birth and a recurrent cancellation. And those are the factors we're going to focus on tonight. So I'll run through the study with you. And there's a couple of parts I want to focus on. So interestingly, the data is actually kind of old. So they looked at patients from 2014 to 2017, which maybe ask, why did they wait so long? And why such small numbers? They could have way bigger numbers. Why is this data not published before? Didn't make a huge amount of sense. But I think it was interesting to see, what they looked at there in terms of dates. So I wish it was more up to date, but that's where it is. The data included 17,459 patients with a first autologous IVF, so there was no egg donor involved. That resulted in a cycle cancellation. So all those poor people started their IVF cycle and they got canceled. We all know how badly that sucks. My heart goes out to those where we have to cancel them. It's horrible. And then they had a second autologous cycle within the study period. They defined cycle cancellation as an IVF cycle started with the intention of either fresh or freeze-all with subsequent frozen embryo transfer that was terminated during the ovarian stimulation prior to egg retrieval. And they excluded patients that actually had a trigger or had an egg retrieval, but they got nothing out of it. And if there were multiple IVF cycles and multiple IVF cancellations, only the first cycle cancellation was included. So what they ended up with was a total of 13,340 cases altogether that were included and analyzed because they had to exclude people who had fertility preservation. They excluded people with those multiple cycles, and they excluded people who didn't have enough data. So they ended up with 13,340 cycles, which is a massive database. I mean, that gives us super robust statistical power when we analyze those numbers. The primary outcome, live birth from the first embryo transfer, and the odds of recurrent cycle cancellation. So those are their two main things that they were looking at. Live birth was defined as a cycle that resulted in the birth of at least one live-born infant, with the delivery of multiple infants still counted as one birth. And they only looked at ones that were from the first embryo transfer, either fresh or frozen, from the second IVF cycle because obviously the first one was canceled. So really important. And then in order to assess the effect of the change in the stimulation protocol on the second cycle, they excluded patients with multiple stimulation protocol changes because it would make it kind of chaotic. So that left them with 13,135. So there really weren't a lot of patients that did that. Change in protocol was defined as the exclusive use of either an agonist flare, so that's like the microdose Lupron flare, agonist suppression, which is the long Lupron protocol, or antagonist in the index cycle, and then the use of a different protocol in the second one. So they weren't actually looking at the gonadotropins. Did you use Gonal-F? Did you use Menopur, Recaval, so on? Puregon. They're actually looking at the baseline part of it, which is how did you prevent yourself from releasing the eggs? Did you use microdose flare, which supposedly has a great option of promoting growth of weak ovaries to produce eggs? Did you use the long protocol, which is kind of an older protocol, or did you use the antagonist protocol, which is by far the most common protocol used right now? And then they did stratify the results with low response, which they called poor responders, or high response, and then withdrawal from treatment. They did look at a bunch of demographic factors: maternal age, obviously the BMI or race, smoking status, number of pregnancies, number of babies you've delivered, infertility diagnosis. And they had a mixed race variable for those who had more than one race noted. Okay, so I will quickly go through this part. So this was just demographic comparison of what happened in the first cycle versus what happened in the second cycle, and if they were canceled even in the second cycle. Okay, so days of cancellation, quite quick in the first cycle, 8.75 days, although arguably not quick enough. Longer if you canceled in the second cycle. Maximum baseline FSH, these are obviously fairly high, so 10.37 average versus 12.97, which is starting to get into a worrisome category if you canceled in the second cycle. It was only 9.99 in the ones that were not canceled. AMH 1.19, 0.61 if the second cycle was canceled, 1.41 when they were not canceled. So there is some difference there in terms of the groups that they're getting. So keep that in mind as well. Stimulation protocol, about 53% in the first cycle had antagonist suppression, which is that common protocol. 12.5% the agonist flare, 13.6% with the long Lupron. In the canceled, they had fewer antagonist suppression, a little bit more agonist flare, which makes sense because that's the protocol we use when we are trying to force the ovaries to respond. And then 9.1% for the agonist suppression, which makes a lot of sense because that suppresses your ovaries quite a bit, not the go-to if you've already canceled the cycle. And then in the not canceled, very similar to the canceled in the second cycle, 54.9% had antagonist suppression, 20.9% had the flare, a lower number had the agonist suppression. Cancellation indications, the vast majority is for people that were being canceled because their lining wasn't developing in time when you could easily do an FET. Concurrent illness, obviously there are some people that were sick for whatever reason, and then there's a whole bunch of reasons why people withdrew, including, small percentages. Okay. This is hugely important. So demographic factors that were important. If you look at the referent, which is the group that they compared them to for age less than 35, you can see very clearly that live birth is drastically reduced the higher you go up in age. So it's a 45% reduction just going from 35 or less than 35 to 35 to 37. And keep in mind, these are all people that canceled their first cycle, okay? So that's a huge issue right there. So that means the older you get, if you've already had a canceled cycle, the lower your chances get. As low as a 91% reduction if your age is over 43. So huge reductions in live birth rates, highly significant. Same thing for recurrence of cycle cancellation. So if you're less than 35, which was the reference group, and you're comparing that to someone that was between 35 to 37, had a 68% increase in the risk of getting another cycle canceled. If you were 38 to 40, you had a 131% increase in risk. If you were 41 to 42, a 161% increase. And if you're over 43, it's a 294% increase in your risk of cycle cancellation. BMI, it was mainly significant when you were comparing less than 25, which is quote unquote considered normal, to 30 to 35, which is considered obesity. And there you saw a very significant increase you saw an increase in live birth compared to the less than 35. So that was important. There was a 20% increased risk or chance there. And they actually had an increase in the risk of cycle cancellation. So that was kind of ironic that they're higher risks of cancellation, but a higher live birth rate. Once you're over 35, they saw no difference in live birth rates, but they did see an increase in the risk of cycle cancellation again. Smoking, 24% decrease. So please, we preach about this all the time on the show. Stop smoking. I realize it's tough. I know it's difficult. I realize it's an addiction. It doesn't matter. Stop smoking if you're going through fertility. And they did not see a change in cycle cancellation, but they did see a change in live birth. The rest of it kind of hit and miss information, the infertility diagnoses and stuff like that, I won't go through. Male factor was borderline, kind of a trend. The main one was diminished ovarian reserve, which decreased your live birth rate and massively increased your cycle cancellation. Unexplained did as well. Okay, here's the nitty gritty. I think you should be able to see that. You can see that pretty well. Yeah, okay. So AF does not mean what you think it means from all our social media. It means the antagonist flare protocol. AS was the antagonist suppression. So that's like your long lupron. You started on cycle day 21, it suppresses you. And then antagonist was just the A, okay? So a lot of these numbers are a jumble, but I underline the ones that are important, okay? So if you look at switching over from an antagonist suppression, which is your agonist suppression, which is your long lupron, to an agonist cycle or antagonist cycle, which is like your cetrotide, your orgalutran, they did have a highly significant decrease in cycle cancellation, 32% less cycle cancellation, and a 73% increase in live birth. So if in your first cycle, you did your normal suppression with the long lupron protocol, and then in the second cycle, you moved to an antagonist protocol, the patients did way better. 32% less cancellation of the cycle and a 73% increase in live birth rate, which is huge. And again, this is like very robust data from a very large database, okay? In the next part, you can see that if you had an antagonist and you switched to, and you failed, so you got canceled with your antagonist, and you switched to the agonist suppression protocol, which is your lupron protocol, you had a 17% decrease in cycle cancellation, and you had a 36% increase in live birth. Now you're all probably scratching your heads going, wait a minute, didn't you just tell us the opposite of that? I did. So the key to this is it's not doing the same thing over and over again. It's changing things because some patients respond better to one medication than another. So if you didn't have a good response with your antagonist protocol and you got canceled, maybe you will do better with an agonist suppression. And that's the key to this. It's to not do the same thing over and over and over again. When they looked at patients with prior cycle cancellations for low response, If you switched from antagonist flare to antagonist suppression, you had a 75% decrease in cycle cancellation, huge, and no difference in live birth. When you looked at the group where they did antagonist suppression and then they switched over to antagonist, 41% decrease in cycle cancellation and a borderline statistically significant 65% increase in live birth. It's 0.53, definitely a trend. It probably would have met the appropriate criteria to be significant if they just had more numbers. And then finally, when you went from antagonist to antagonist suppression, you had a significant 36% increase in live birth. So what this tells you overall is not to choose one of these versus another, although overall they did have the lowest success rates with the antagonist flare. What it does tell you is that your best bet is to change things. So when you go to the fertility doctor and they say, just do the same thing again, and then again, and then again, and they're not changing anything, that makes no sense whatsoever. You have to change things up because it's very clear from very robust data that it's critical for you to change things up. Do not stick with the same protocol every time. So is it a factor of fiction that you should change your protocol? It's an absolute fact that you should change your protocol. There's no question that it will benefit you with higher live birth rates, lower cycle cancellation, especially if your cycle was canceled in the cycle before. Now, does this apply to people that are simply embryo banking? No, it doesn't. These are for people that canceled their cycle previously. So if you're making 10 embryos and you made 5 in the first cycle, and that's a reasonable response for you, you don't have to change a thing. You can make 5 more and use the same protocol. But if you got canceled, this data very much applies to you. It should be considered before you do another cycle. Hope you found that useful. We will be splitting that off as a separate YouTube video. Make sure you like, comment, and subscribe, please. And we're going to take your questions now, which, judging from Tarek's very worried face, looks like there's a lot of people that have questions. So, yeah, fire away.
Hello, dear Dr. Victory and dear Tarek. How often and in which intervals do I need to proceed having IVIG? First infusion was 7 days before transfer. Second was positive beta. How to proceed?
Yeah, most people won't do much more than that, at most 1, and it's so bloody expensive that we generally try to avoid it. I mean, if you can afford it, great, but out here it's $5,000 a pop, so that's very pricey. By the way, for those of you that are wondering, I do believe we found a way to get SCIG back for our Ontario patients. I'm working on the final details, so again, please don't inundate my nurses, but I do believe I've found a way to make it work.
Hi, Dr. B and Dr. T. Good start. What is the cutoff for progesterone in nanomoles per liter before starting PIO injections in a medicated cycle?
What is the cutoff before starting? I don't get that.
What is the cutoff for progesterone in nanomoles per liter before starting PIO injections in a medicated cycle?
I don't get what they mean by cutoff. I mean, you should have very low progesterone levels before starting your PIO. So I'm not sure I understand that question. If you mean what's the timeline cutoff, we don't like it when our patients are exposed to too long a period of estrogen. So in a medicated cycle, we try and make sure it's less than 30 days maximum, preferably less than that. But there are some patients that take longer because their lining isn't responding.
And Dr. B and T. What are means to avoid progesterone rise without LH surge during IVF stimulation? Are there other alternatives to dethlamexel?
What makes your progesterone rise even without an LH surge? You will secrete some progesterone from conversion peripherally of other hormones, especially when your estrogen levels go sky high. So there will still be some conversions. Yeah, so that's where it's coming from. I gotta take one from TikTok. What is the wait for surrogacy in Canada? It very much depends on the patients and what you're looking for. If you are looking for a surrogate because you have a, very kind of complicated history, there's trauma, you lost your uterus, you've had cancer, you'll usually find someone very quickly. If it's a couple from overseas and they don't speak the language that well, it can take longer. So on the shortest, we found people within a month or two, and on the longest, it can take years. Yeah.
Been on Lupron plus letrozole for 3 months. MRI, it still shows endo and adeno. Estrogen is less than 5. Should I still proceed with FET?
Well, you can't get rid of adeno. You can only suppress its activity, which is likely very beneficial and useful because there are lots of studies showing that adenomyosis suppression can essentially almost normalize your results. From an endo perspective, the only way to get rid of endo is to operate. You're not going to get rid of endo. And by the way, MRIs are useless at picking up superficial endo. So all the people out there that are getting pushed into doing MRIs, you are wasting your time and your money. Don't bother. If you think you have endo, you either need to get surgery or you need to get suppression and then pray that that does enough. I'm a big believer in suppression and surgery, but it's up to you. There is, by the way, now a Canadian test on the market. Oh, I didn't tell you about this. There's a Canadian test on the market developed by some people that I know, and one of whom, the main person I actually met at that conference in Chicago on the weekend, called Endomere. And Endomere and its founder are actually going to come on the show soon and talk to us about it. So they figured out how to take a blood test and test you for endometriosis. And it is roughly 1/3 the cost of doing Receptiva DX. So I'm not 100% prepared to get behind it yet, but I'm prepared to offer it to people who don't want surgery and have unexplained infertility and want to know before they expose themselves to surgery. So I'm not sure I'm going to use it to decide yes or no, because I still have my gestalt and there are ways to figure out if you have endo without doing tests like that. But I think it's a worthwhile test for some people. And because it's way cheaper than the Receptiva DX, I can at least be kind of partially supportive of it. I may be biased too because it's Canadian, so I don't know.
Team Canada.
I gotta extract that part from my brain. But anyways, yeah.
Water broke at 36 weeks, first pregnancy, no found reason. More likely to have another early baby?
Yes, yeah, you are. I would probably offer to do fertility testing to see if there's any bacteria in the uterus that don't belong, although you did very well making it to 36 weeks, so probably not a huge issue.
When do you anticipate the St. Catharines location will open?
In a month.
Had a miscarriage, had a cycle later, very short. Is it less likely I'll get pregnant this cycle?
No. If anything, there's some evidence to suggest that your fertility increases weak. And I generally don't tell people to use that as a marker or a metric, but it certainly shouldn't decrease your chances.
And you have surgery to unblock tubes. My doctor said they don't have to do that anymore.
Yeah, there's 2 ways to do it. So there's a interventional radiology approach where they go through your cervix with a wire and they start injecting dye and they find the tube and they literally, there's a ball at the end of the wire so it can kind of be threaded through your fallopian tube and then you literally bust through the tube. Now, how well does it work? It's terrible. It's got a 40% success rate, so it's not very good and it hurts like hell. But it can work in that 40% of people. I think I've had 2 patients do it and it didn't work in either one of them. One of them was one of the funniest patients I've ever had, by the way. I still remember her very well. The other approach is to have us operate and go in there and fix the end of the tube. So if it's the end of the tube that is blocked, or there's kinking of the tube from endo or whatever the case is, there are ways to fix that. So kinking you can fix by dissecting adhesions, and end of the tube you can fix by literally cutting the tube into strips at the end and then burning on the outside, which causes it to curl back because you kind of burn here and it pulls it back. And so you recreate the end of the tube. It's called the flower petal technique because it makes the tube open up like a flower. It is very technically sophisticated. I don't know anyone in my community other than me that does it. And in fact, I don't know very many people anywhere that know how to do it. So I do it occasionally for people that don't want me to take out their tubes. But if both your tubes are blocked, you're much better off doing IVF. Your chances of success are way, way higher, but there are options for you. I think people, as a general rule, just like having options. I think part of the reason people listen to this show is to know that there's more to just what their doctor told them. And I think we're good about that. We generally will outline all the possibilities instead of just, hey, you need IVF and you need IVF and you need IVF and everybody that walks through the door needs IVF.
Options are the way to go.
For sure.
When you go to a buffet, you find a bunch of options.
Yeah.
When you make a Subway sandwich, there are options. They don't just say,
None of those are good ones, by the way, but there are.
but everyone appreciates.
Yeah, yeah. When you go to buy a car,
There are a lot of options.
Yeah.
Absolutely.
Yeah.
Where is there no options?
How good was your recent car driving experience?
Top tier.
I'm trying to convince Tarek to buy a phenomenal car, so we'll see how it goes. Yep. He's going.
It's not even.
Off camera. Yeah, nice car.
I had a laparoscopy
Okay,
and the doctor confirmed it's inactive endo.
okay.
What does inactive endo mean?
So sometimes endo will show up and your immune system will successfully kill it off. And so you can see the marks where the cells were, but they're not alive anymore. So that's inactive endo.
One from the real bottom, I scrolled all the way down just to check. Can you eat deli meat while pregnant? Really missing my local butcher's deli sandwiches. Also options.
Yeah. So the problem with deli meat is it contains a high concentration of something called nitrates, and nitrates are not good for you or your baby. So, I mean, if you're dying for a turkey sandwich, have a turkey sandwich or whatever. But should you do it every day? No.
Yeah, that was disappointing when I discovered that nitrates were bad for you.
Oh, you like deli meat?
I like all meat sandwiches.
Yeah, you know, we have it at the cottage when we have a ton of people there because it's just easy.
So easy.
You come in off the lake, you make a sandwich, we
Yeah.
just leave it buffet style, but it's probably hideous for you.
Oh, it's
You're way better off cooking a turkey or a chicken.
100% slicing it up.
Slicing it up.
Yeah. But you know, late night, watching TV, got a little gurgle in the stomach, walk up to the fridge, mayo, mustard,
Yeah,
tomatoes,
yeah,
some variety of meats. If you're really living it up, cheese,
and you're good to go.
pickle, crunchy baguette.
Okay, I got
It's
it.
good.
For reference sake, Hajj is coming up, the Muslim pilgrimage, and when you can't actually go on Hajj, you're supposed to fast for 10 days. So my very devout Muslim friend Tarek here is currently starving, and that's probably why he went on a food rant.
The question was brought up
I know.
by the nitrates in deli. I'm simply echoing, I agree. Good old deli meat.
Yeah, but it was when you started drooling when you said pickle that I got worried.
Well, you know. I'm
We
hungry.
have sushi waiting for us, and I thought to be a decent human being, I would not eat before he did. So after the show, we were going to
See, Charles echoes with a little sub sauce. Mm.
a little sub sauce.
Yeah,
There
of
you go.
course. Of course.
All right.
Yeah, continuing on, fertility show. It's not sandwich hour, like Dr. Victor there. Do you recommend any specific testing for IVF pregnancies versus natural pregnancy?
Yeah, you know, there's a whole guideline now from the Society for Maternal and Fetal Medicine. So they are recommending fetal echocardiograms, more close monitoring. You can do either the early first trimester screening or enhanced first trimester screening, or NIPT. Most people will push for NIPT if you're spending that much on the IVF. Spring for the NIPT as well if you need to. All of those are reasonable. And then the major thing is don't wait past 39 weeks. You should be induced. There's a very popular fertility personality on Instagram who is how do I say this without getting in trouble? Who I know. And she reached out to me to ask if she should be induced at 38 weeks or at later. And I sent her the guidelines, which clearly say 39. Apparently her doctor was saying the baby's going to die after 38, but that's absolute nonsense. It's not true at all. So you can wait till 39 and the evidence supports that. But don't wait past 39 because your risk of stillbirth, preeclampsia, admission to ICU for mom, admission to NICU for baby, risk of cesarean section all increase. Yeah.
Hey, Dr. B&T. Yesterday had our third and final IUI.
Yeah.
What do you suggest to increase chances of implantation? Also, is my cramping related to the IUI?
Hard to know, although if you had multiple eggs, your cramping likely is related to the release of the eggs. How to increase success? The only thing that's ever been shown to increase success, aside from healthy diet, healthy eating, exercise, stuff like that, is to have more sex. That's it. There is nothing else that works. Okay, you know how I told you I got another one of those phishing messages?
Yeah.
Yeah, those are so funny. Do you guys all get those messages where someone says, "Hey, how are you?" And you have no idea who's calling? So I love to mess with those people. I think it's so funny. So I usually either tell them I work for the FBI or Interpol or something like that.
Oh, you go all the way to
I'm not
that.
tracking their number, and then you never hear from them again. Yeah, so she's apologizing for contacting me after we quote unquote met at the fashion show. I wasn't at a fashion
Oh,
show.
you didn't go to the fashion
No,
show? I was there
although-
actually.
Although I am trying to go to a fashion show in New York in October.
Oh, really?
I am, yeah.
Wow.
Yeah,
That's cool.
I do love my clothing, so there.
Sure,
Yeah.
that's something.
Not scrubs, by the way. There's no fashion associated with this. Yeah.
Good evening, Dr. V and the famous Dr. T.
Oh,
Wow.
I've been
This guy-
supplanted by this guy
This
now.
guy
Wow.
knows how to write a question. This guy can ask anything.
Yeah, go
Back
for
to
it.
backs this guy. I'm wondering, how long after having a perineal abscess drained surgically before doing another FET?
A while. You need to absolutely make sure the inflammation and the infection are gone so that there won't be any inflammation when they do the FET. I would say months, but to be honest, that's either a plastics or a general surgery question. Let me take 2 questions from
Sure.
TikTok. What are the physical signs of letrozole working without needing to do an ultrasound? 0. There is no way to know. Maybe cervical mucus, but it is a super weak indicator. So there are no physical signs. And also, can you find out the gender early with blood work in Canada? Yes, you can. You can do the NIPT and ask for the gender to be added to that.
23 weeks pregnant, wore a Holter monitor and detected triplet PVCs.
Yeah,
Is this worrisome?
nope. Only if you get dizzy, lightheaded, feel chest symptoms, that kind of thing. If you just feel like skipped beat, it's not a big deal at all.
Conceiving odds after C-section, ectopic treated with methotrexate directly into gestational sac.
Oh. Your odds are good, but I'd probably would be wanting to look at the option to fix your uterus, depending on how bad your isthmosele is. That's a cesarean scar ectopic. Those are actually often fatal.
Oh, wow.
Yeah, because you can't get the area to contract, right? There's the tissue so thin that there's no way to stop it from bleeding. So they actually have to take a needle and use ultrasound and go into the sac and terminate the fetus with the methotrexate.
Wow.
Yeah, I've had to do it once. That's hardcore obstetrics.
Have no questions for once, says Charles. Pregnant, and thank you so much for all your advice again.
Chels, congrats. That's awesome. Big round of applause for Chels. Thumbs up, lots of hearts. That's awesome. Good job, Chels. Yeah, my FET is tomorrow. It's at 2 cc, but euploid. Any last tips? Don't drink, don't smoke, take lots of vitamins and supplements, lots of prayer. Lots and lots of prayer.
If a fibroid is bumping right up to the uterus, but not in the cavity yet,
Uh-huh.
do you usually recommend medication to shrink before egg retrieval, FET?
Before egg retrieval, it's irrelevant. Before FET, If it's more than 4 centimeters and it's adjacent to the cavity, it should be removed. If it's at all indenting the cavity, it should be removed. And there's good data from that from Elizabeth Pritz, who's a well-known fertility specialist in the US. She did a great meta-analysis, not once, but twice, in fertility and sterility. And I actually got asked that exact question on my board exam in the US.
Wow.
And they said, so you would tell your patients to remove the fibroids based on what evidence? And I said, I quoted the study and I said, Elizabeth Pritz. And it's a meta-analysis. And they said, you consider that good evidence? And I said, well, you guys put it in your guidelines. So I guess I could ask you that question. And they moved on. So it was like a great answer for that test question. Yeah. They like put you on the spot. Do you know your data? Do you know your studies? It was pretty wild.
Wow.
Yeah.
Aspirin up until delivery, even if I have low blood pressure, does aspirin increase hemorrhage risk if taken until birth?
No. So yes, continue it, and no, it doesn't increase hemorrhage risks.
I have high TPO antibodies. What can I do to lower them? And any thoughts about a good IVF protocol?
Selenium and inositol will work really well. You may need to overdrive your thyroid a little bit if your TSH allows it. So if your TSH, for example, is 3, you should go on thyroid supplementation. That'll help. IVF protocol, I need to know more about you, so I can't tell you without specifics. But
What do you suggest for moderate third trimester anemia?
anemia,
Anemia.
iron infusion or iron supplementation.
Dr. B and quote unquote Dr. T.
Yes.
I'll take that.
Yeah.
Wondering
Yeah.
if you would even recommend a retrieval for someone with endo-adno if they have an AMH of 0.28 and an FSH of 26.9.
Oh, wow. Would I recommend it? No. Would I have a long discussion with you about your options and offer it to you? Yes, because I feel, like I said earlier in the show, that everybody should have choice and you should know what your choices are and what your options are and what the chances are and so on. But would I actually do it? No, I would, or sorry, would I actually recommend it? No, I would never recommend that to somebody. You got to remember that with your FSH that high, the chances you're going to get a lot of eggs is very, very, very low. And if you have endo and adeno, we're additionally talking egg quality issues, miscarriage issues, aneuploidy issues, implantation issues. Those are modifiable, but they're not something I can completely normalize. And so there's a lot going against you there that would make it challenging. So I would sit you down, break down every part of the process, tell you how many eggs you need, what you could expect as outcomes at each step. And then, you know, talk to you about what your options were, whether we use your eggs and make an embryo and then put it in a surrogate, use your eggs, make an embryo, put it in you, or use donor eggs, put it in you, use donor eggs, put it in a surrogate. There's all sorts of options available, but you need to go through each one and know what the costs are, what the outcomes are, what the chances are, and so on.
Hi, Dr. V and T. What happens when you suppress for endo in an older patient and they don't come out of suppression after the last dose of Lupron-Letrozole? FSH, LH continue to rise and E2 tanking.
Wait a month. But if your FSH and LH are rising, it means you were already going into menopause. So in those cases, there are patients that actually do need some estrogen to rejuvenate the lining. There is no alternative. If you're going into menopause, you can't, fix that. Some quickies. Recommended caffeine intake while pregnant, no more than 1 cup a day. How long should you wait for implantation after polyp removal? A month, wait for your next period. High-dose fertility testing give you more info about retrieval or transfer or both. It gives you 0 information about retrieval. It's all about transfer.
Ways to make a sono less pain.
Watch our video. We have a great video on YouTube on how to properly do a saline infusion sonohysterogram. Make sure they walk you through every step. Take some pain meds before you go. And I'm just talking like ibuprofen. Make sure they warm their instruments. Make sure they are talking to you as they do it. Don't stick the balloon in Timbuktu. Don't overinflate the balloon. And then when you're flushing in the fluid, go extremely, extremely slowly. If you flush in the fluid slowly, there's literally no pain, like none. It's when they bang in the syringe and then patients go, oh, and then the uterus starts to spasm and the tube spasm and it's game over. I could be the most gentle post, flush and it's still going to hurt like hell because everything's in spasm. But if you go really slowly, there's no spasm, so it's fine. Watch our video. It's actually a very well done video. God bless the patient that's in it. I love her dearly. She tolerated it like a champ. It went really well. Easy.
Hey, Dr. V.
Yeah.
Low dose protocol for women over 42. Follistim 150 only for 5 days, followed by additional Menopur 75, Dexa 1 milligram, and a dual trigger. Your thoughts?
Okay, say that one more time because there was a lot there.
For women over 42,
Yeah.
Follistim 150
Okay.
only for 5 days,
Okay.
followed by an additional Menopur 75,
Okay.
Dexa 1 milligram,
Sure.
and dual trigger.
Yeah. Reasonable. There is evidence that shows that delaying the onset of the use of Menopur is actually detrimental. So there's no reason to wait the 5 days. But that's a reasonable protocol.
I just did a retrieval, but chose not to do PGT testing based on age and other issues.
Sure.
I do have the embryo grading. How accurate is the grading a predictor of a live birth?
Well, it would depend on your age and a lot of other different factors. We do know that poor quality embryos, those that have a C grade in them or D grade, definitely don't do as well as A's and B's do. But there's no kind of one-to-one correlation with live birth. So we know the chances are less if you compare C grades to A grades, or even to B grades. B and A are very similar. But C compared to A or B has a lower chance. So if I remember correctly, you and I reviewed this on the show 3 years ago. It's been a long time. 2 years, 3 years ago. It's like a pretty substantial decrease. You're looking at like a 65% decrease in success when you're going into C grade.
Receptiva test for endo was negative. However, I have random mild cramping throughout my cycle. Is there any other testing for uterine inflammation available? I've had 2 FET failures of euploid embryo.
Oh, well, yeah, we would use Fertility for a case like that. So you want to get checked out for whether or not there's infection, whether or not you have immunological problems. And remember, Receptiva at best has like a 92% detection rate. And Stephen Young, the guy who gave that presentation, he's actually the guy that developed it. And even he said in real world applications, it's not nearly as good as the stuff they published. So realistically, it is not that useful. So, surgery is always still an option.
Hi, Doc.
Hello.
Would you do IUI on women 41 years, women with optimal sperm?
Sure. Yeah, you certainly can. I wouldn't do it over and over and over again, but up to 3 tries is reasonable. Yeah. No reason not to.
Hi, Dr. VNT. For high natural killer cells, how long and what dose of prednisone is recommended once pregnant? Also, how often should intralipids be done in pregnancy for high NK cells?
So prednisone, we continue until 12 weeks. Some people do shorter because they're worried about the risk of cleft lip, cleft palate. I've only seen it once, but it is a risk. So there are trade-offs in using all medications, but we continue to 12 weeks and we use 25 milligrams. Anything less than that, you're really not getting any effect. Anything higher than that, there's a lot of side effects. So we kind of hedged our bets and went with like a medium dose, medium low actually. In terms of intralipids, you can look at studies that have used it up to 12 weeks, or you can look at studies that use it through the whole pregnancy. We just tell our patients you can do either one. The vast majority of our patients want to continue it every 6 weeks because they're just nervous. So we just let them do what they want to do.
Dr. B and Dr. T. We are a patient of yours. Well, it's fantastic to hear. That's great.
I think they mean mine in this case, maybe yours, I don't know.
Well,
Yeah, if Tarek's starting a side gig, I would like to know people. Yeah,
patient of
a
ours.
patient of ours, yeah.
Okay.
Yeah.
Do you ever deal with the immune system issues and what it needs to help support implantation? Perhaps a protocol you have, you're the best.
All the time, yeah, that's a big part of what we do. We do help people with immune problems, so, yep, we do that frequently.
Regular thing we do over here.
It
Right,
is a
Dr.
very-
Victory?
It is. Any rate, could flushing too quickly cause spasms, make a tube be blocked for mucus temporarily painful? Yes, not for mucus, it just actually causes the tube to spasm and it takes a long time to relax. So it wouldn't be a mucus plug, it would be an actual spasm plug.
Can hirsutism
Yeah.
be
Too much-
normal?
Too much facial hair.
Oh, or
Or
normal?
body hair.
Or is it always a sign of hormonal issues? Can it be reversed with hormonal balancing?
Yeah, it's not always a sign of hormonal issues. It can be fixed with hormonal balancing. And I mean, as a Middle Easterner, hair is kind of common for us. So even some of our women are hairier. It's not necessarily normal to have facial hair or chest hair in a woman, although chest in a Middle Eastern woman can be relatively common. But you'll see arm and leg hair and stuff like that all the time in women from the Middle East. That's our culture.
It's our culture.
Yeah. Less so facial hair. Facial hair is more hirsutism.
Hey, sweet tea, what's up? Wow, that's great.
Sweet tea.
This is all good.
I'm just gonna sit.
Hello, my favorite doc.
Yeah,
That's you.
we don't know anymore.
Oh, this is two intros for me.
You never know.
I know, I'll take that. Recently switched clinics.
Okay.
Oh, this is great. The doc said they are evidence-based clinic.
Okay.
And she said Lupron and letrozole have recently proven no evidence to help endo FET.
There are 3 studies on
Awesome.
that. Yeah. So there are actually 3 studies. Tark and I just made an endo video. I posted all 3 in the video so you can see them. So whoever told you that doesn't know what they're talking about.
But this is an evidence-based clinic.
Apparently not.
Apparently not.
Yeah.
Hi, Dr. B and Mr. T. Thank you for all you do. I'm about to have lap. My surgeon does not want a period for 3 months. When do you advise I start Lupron letrozole? Is there a specific day of the cycle?
I mean, if you have endo, I'd start it soon. It doesn't matter what day of your cycle, because you'll be suppressed when you go for your surgery. And if you're going for your surgery, then you'll have less for them to do and it'll make it easier.
Dr. B, this is my first time being in your live.
Oh, wow. Cool. Welcome to the live.
I'm now 41
Okay.
and dying to have a second baby.
Okay.
And I weigh 65. And I weigh 65 now
So
at 4'11".
kilograms. Yeah.
Kilograms. 41 height.
Okay.
I delivered our firstborn.
4'11" or
4'11".
Yeah,
4'11".
Okay. Yeah.
How can it increase my chances of getting pregnant?
Vitamins, healthy diet, make sure your weight's good, which yours is reasonable. And you might want to reduce your weight a tiny bit because you're so petite, but very, very little. I don't think that's a major factor. No smoking, no drinking, no drug use. Have sex every day or every 2 days. That's the basics. Yeah. See a fertility specialist.
What causes luteal phase nightmares? And how can I manage them?
What causes luteal phase nightmares? I don't know anything about luteal phase nightmares.
Is that a real medical thing, or is this like a dream?
I can tell you my nightmare. I do now snore, which is horrific, but I will share that on international television. There are no secrets here. And my wife bought this like mouth tape. Have you seen that?
Yeah, I have seen it.
So you tape it to your face, and then it keeps your mouth shut so that you're forced to breathe through your nose, and then supposedly you snore less. Yeah, like 10 minutes into it, she rolled me over because I was snoring
You know, I was-
right 2 or 3 years. So I don't think that mouth tape thing works, man.
I saw
I
a
ripped it
video.
off.
I saw a video on a new mattress.
A new mattress.
Yeah.
Okay.
And this mattress, you plug it in.
Okay.
It heats and cools the bed based on your preferences.
Okay.
But when it detects snoring,
Yeah.
it tilts you up
By itself.
by itself.
Yeah, I'd kill everybody in sight if they woke me up.
No, it doesn't wake you.
I'm already getting, you know,
It just slightly increases the back of the bed. Like,
I'm already getting woken up by my kitten every morning at 5 to, play. So I'm,
every time.
yeah, purr time. Does your cat wake you up in the morning?
Hell no. My cat knows better to ever come near me.
Are your doors closed?
Yeah, it gets so hot upstairs. I close the door hoping the AC cools more.
Oh, really?
That's my strategy.
Yeah, and it doesn't scratch at your door? Probably goes to your kids.
Oh yeah, all the doors are open for the other kids. I don't know where.
Go by the kids.
Don't go anywhere else.
Yeah, that doesn't work for me. I'm an empty nester, man.
Yeah,
Cat-
sure.
The cat wants food and play. He wants to play. He wants
Even
to
at
jump.
5 in the morning, they'll start that
Oh, he wants to play, and he'll rub all against me.
until you open
You
like.
saw how loud he was when
Yeah,
I was the
very
cutest
loud.
little guy, yeah.
Shockingly
And
loud.
super friendly.
Little body, but very loud.
Yeah.
Yeah, it's a nice cat.
He's a very cute kitty, yeah.
Hi, Dr. B and Dr. T. Only good things can happen. So I think we should.
Oh, Soraya's back.
Welcome back, Soraya. We missed you.
We missed you, Soraya, yeah.
I think it's also important to mention that this is now officially 9:02.
Yes.
So this automatically puts us into fertility after dark.
Fertility after dark. You can
Yeah.
ask your more wild
You can
questions.
ask wild questions now,
Yeah.
and you may get wild answers.
And you got 8 minutes left because Tarek has to eat it.
There you go.
Yeah,
We are a patient of yours.
okay.
Let me know if I read this. Do you deal with? Yeah, we
read that one.
Yeah,
Yeah.
they asked it twice.
Yeah.
Can Clomid be used to build sperm count?
Yep. For guys that have low signal from their brain, low FSH or low LH signal, you can use Clomid to boost it. Sometimes even when the signal isn't low, you can get some improvement. Guys with low testosterone, guys that have been using steroids, stuff like that. Yep, it works. Excuse me.
We'll go to TikTok for a bit.
TikTok, yeah.
Hi, Dr. Big T. How do you treat a patient HLA DQA match? Is their impact?
It depends on what you read and what you believe, but you can use SCIG, you can use heparin, intralipids, that kind of thing is generally what we turn to for the DQ alpha. If you talk to the guys at Fertility, they will tell you to use LIT. Now, my good friend Dr. Zaneku says that's useless because you're just giving people what they already have, which I agree with. But Dr. Panagiatis in Fertility says there are other HLAs, and by correcting for those, it may influence the DQ alpha. There's no scientific proof for any of this stuff, guys. So it's all trial and error, but those are the things we use.
And a follow-up to that question is, would it be better to proceed with a GC?
It depends on your history. I would need to talk to you and see what you've done. I mean, it's certainly a option and probably a very good one. But it's interesting, if you actually look at the studies on DQ alpha, 3 of them said it was like the worst thing ever. And then there were 2 or 3 more that said it made absolutely no difference whatsoever. So who knows? I mean, I don't think the jury is in yet on all of this stuff.
Love the mug.
Isn't the mug cool? One of my patients gave me this mug. Super cool mug. Hey, I love it.
Do you believe
I do love mugs, by the way. Yeah.
You do love mugs.
Yeah.
You know, I love mugs too, to be honest.
You
But
know-
I'm very particular about mugs.
You know, we never pursued making merchandise to contribute to like an
Oh.
IVF fund.
We should do that.
We got to do
I
that.
should do that.
We
We'll
gotta
do
do
the other thing today.
Yeah.
You know what? I'll add that as a to-do thing for me.
We got to do that. Let's
Yeah,
make some
we'll do that.
merch and then we'll just donate it to Fertility Friends Foundation
Sure.
or we'll start our own
Let's not
thing
have
or
fun.
whatever. Yeah.
Do you believe a hydrosalpinx needs to be removed before a transfer,
Yes.
even if there is
Yep.
spillage?
Yeah, if it's a hydrosalpinx, the fluid that's in it is toxic. And if it's getting into your uterus, it will kill an embryo. It's a 50% reduction in success. So,
After 2 miscarriages now, I don't get pregnant. What are your suggestions?
see a fertility specialist and get tested. You need your uterus checked. You need a salient fusion son histogram, probably infectious and immunological testing, hormone checks, sperm quality check, all of that stuff.
33 years old and an AMH of 9. What IVF dosage will you recommend?
Well, I need to know you to give you specific answers, and you need to be my patient. But I can tell you as a general rule that it is becoming more and more clear that high doses of medications barbecues your eggs and that should be avoided. So we use a maximum dose of 375. In most people, we're trying to stay around the 300 or less mark. We don't go super low either because I don't believe in doing mini stims that often. There's a very select group of people that that's good for, but a normal stim should probably not exceed the 300, 375 mark. A study we reviewed 2 or 3 weeks ago when we did the machine learning one on the show here, you can look back at our YouTube, showed that 225 was the optimal dose, not just to get the best outcome, but actually to get the most number of eggs. There were more people getting a higher number of eggs with 225 than with higher doses. So it doesn't make sense to be pounding people with drugs. Don't do that.
Hello, I am 49 years old. I have 2 10-centimeter fibroids
Oh,
and smaller ones in my uterus.
yeah.
Would you advise I get a myomectomy and embolization? I'm hoping for my fertilized eggs implanted once healed.
Okay, so 10-centimeter fibroids, I definitely think should be removed. I don't think anyone would question that. I would certainly want to sit down, see where they are and the location, how difficult it is and so on, but those are very large fibroids. They are likely deforming the cavity of the uterus, and certainly if they are, they should be removed. There's good evidence to support that. From the standpoint of that facilitating 49, right? 49-year-old eggs implanting, at 49, your chances of success are unfortunately extraordinarily low. So if you're talking about using your eggs, I don't know that that makes a lot of sense. That's a pretty major surgery to go through for a very, very finite chance. But I mean, it's a discussion you have to have with your doctor or with me or someone qualified who can spell out the details for you and give you your risks and benefits. One last question?
Sure.
We still have, we got 4 minutes. Well, I know we got 3 minutes. 3 minutes. What we got?
Oh, regarding the nightmare,
Yeah.
there's some follow-up to that. I think it's a
Interesting.
concept.
Sure.
Yeah.
Yeah.
My online research shows that it's a common experience of women to experience vivid dreams and nightmares during the later half of their luteal phase.
Okay.
Would love your insight in the future. How do you decrease facial hair growth, especially on the chin and neck? These are all one big question.
I mean, if you're trying to get pregnant, you can't do anything about those luteal phase nightmares because, well, if it's in the later half, maybe you could take progesterone. So try that and see. I've never seen anything about this, so I have to completely plead ignorance. You have stumped me, but I'd have to see if there's a study that suggests that taking progesterone reduces nightmares. Could ask any of our fertility patients, I guess. Facial hair is easy to control, but there is no way to control facial hair that is medical if you are trying to get pregnant. So you can use spironolactone, birth control pill, Lupron. There's a cream. What's the name of that cream? There's a cream you can use that is weak but does work. Make sure your cycles are regular. If you're PCO, lose weight. All of these things can help. Take metformin to reduce your insulin resistance. So there's a lot of different techniques that can help, but they are the medical options are all things you can't do when you are trying to get pregnant. If you are not trying to get pregnant, then those medical options are fine. If you're trying to get pregnant, the only thing you can do is mechanical. So you're either plucking or you're lasering, and laser works the best. Okay, Tarek is starving. Quite frankly, I'm now starving too. So you guys have a wonderful evening. I will answer one last very quick question. Does pelvic floor therapy help to improve endo? Absolutely not. There's no evidence to support that. Have a wonderful evening. I wish you guys all the best. We will be back next week with another exciting edition of Fertility Factor Fiction. Do we have a guest next week?
Maybe we have one guest that's
Trying to get it.
trying to get in.
Okay. Well, maybe we'll have a guest. Maybe we'll have a paper. There are some other exciting papers I want to share with you guys. So we have some stuff to go over. We will talk soon. Have a great night. Good luck on your fertility journey. And remember, you are in control.